It is just a huge honor today to be podcast interviewing Dr. Jason Goodchild, DMD, and Paul Mondock. Paul is a 30-year plus veteran of Septodont, has held numerous roles with increasing responsibility. He is currently the president for North America and Global Sales Services. He is a seasoned industry leader serving on many internal committees and is an original member of the corporate XCOM. In addition to his company responsibilities, Paul is also involved at the board level with multiple industry-related nonprofit organizations. He received his BS in business management from the University of Pittsburgh and his MBA from Temple University Fox School of Business. Nice. And then this bald beauty here, Jason Husband Goodchild, DMD, received his undergraduate degree from Dickinson College in Carlisle, Pennsylvania. He went on to receive his dental training at the University of Pennsylvania School of Dental Medicine in Philly. He is currently the Vice President of Clinical Affairs at Premier Dental Products, Plymouth Meeting, Pennsylvania, involved in developing innovative new products and educating clinicians to include clinical practice. He is also associate clinical professor in the Department of Oral Maxillofacial Surgery at Creighton University. Go Creighton. Lived there 3 years in Omaha. Adjunct assistant professor in the Department of Diagnostic Sciences at the Rutgers School of Dental Medicine, Newark, New Jersey. Dr. Goodchild maintains a private general dental practice in Elkins Park, Pennsylvania, and he can be reached via email at jgoodchild@premierdentalco.com. And as far as currently the vice president of new dental products, you are talking about buffering anesthetic, which has been discussed on Dental Town for, God, 10, 20 years. I mean, this is not a new concept. This has been talked about for decades. And you're going to give me an update today on buffered lidocaine.
Well, first off, let me just say, I think before we started today, I think we both agreed, if I'm not mistaken, that the H in my name stood for Howard. It wasn't wasn't husband, it was Howard. So we're going to say Jason Howard Goodchild. Um, but yeah, we're gonna myself and Paul Mondock I would love to share with you and your listeners about BufferPro. It's a local anesthetic buffering device to deliver the sodium bicarbonate into the local anesthetic. And we lots of interesting news to talk about this a collaboration between Premier Dental and Septodont. But the other thing I wanted to mention is it's good for every local anesthetic. You mentioned lidocaine, but there are 7 different solutions in the United States, and it's good for all of them. So whatever you choose to use, lidocaine or articaine, buffering is going to be great for you.
You said there's 7 different solutions, 7 different anesthetics used,
Yeah,
like
there's
Marcaine and
yeah,
Mepivacaine and
exactly.
all of them.
Prilocaine, lidocaine, articaine. So there's a bunch of different ones, and whichever you choose to use, hey, it's buffering's right up your alley.
Well, I like to start off explain it to me like I'm 5 because the young kids are the most technological savvy, and our show it's massively overweighted by dental students. A lot of dental students say they sit in the back class with their headphones in and listen to these shows. So this might be the first they've ever heard of it. So start out with buffering anesthetic as if you're in dental school and you've never even heard of this concept before. Explain it to
Um,
me like I'm
yeah,
5.
I can go first. Then, yeah, of course, I want Paul to chime in too,
Yeah.
because Septidon being sort of the leader, world leader in this space. But I'll give you sort of the history from my perspective because Howard, I've been looking into this for years and years and years. And as a practicing clinical dentist, I was always looking for ways to make the local anesthetic experience better, not only for the patient, but for me, because as we know, when patients are numb, it's just easier to work on them. Everything seems to go a little smoother. It's a lot less stressful when the patient's comfortable and you can do what needs to be done to get the treatment right. So local anesthetic buffering is simply using sodium bicarbonate to raise the pH of your local anesthetic solution. Now, if you didn't know, or you just never thought about it before, local anesthetics that contain epinephrine have kind of a low pH, give or take 3.5. And my caffeine delivery system every morning is a Diet Coke, and so Diet Coke has a pH of around 3.5. And as you can imagine, that acidic solution, when we inject it, could pinch, burn, or sting. And that's part of what buffering can do. But because it's low pH, actually that accounts for the slow onset time as well. And so that low pH, kind of puts you behind the eight ball. It makes it work slowly and it could pinch. And the reason why we have to have that local anesthetic at that low pH is for shelf life and stability. It actually, becomes more stable, more soluble, the local anesthetic, and more stable, the epinephrine, at a low pH. And so if we raise up that pH prior to injection by adding a small amount of sodium bicarbonate, getting it closer to body pH, we can actually solve a lot of those challenges. We can make the local anesthetic injection hurt less. We can make the local anesthetic work faster. And then the third benefit is that it actually works better, not only in terms of the depth of anesthesia, but the duration of anesthesia. So local anesthetic buffering has some really cool benefits. And you ask yourself, why haven't we done it already, or why hasn't it become super popular in dentistry? And at least my opinion, and that's where I'll hand it off to Paul's. My opinion is that local anesthetic buffering hasn't really taken off because there wasn't ever an easy, elegant, affordable, really, really nice solution, because we're used to working with standard armamentarium. We've got this metal barrel, self-aspirating syringe, a needle, and a cartridge, and anything that sort of upsets that apple cart, that's a relearning behavior, and dentists aren't always really good at that. But I think now with the product we're going to talk about today, BufferPro, now I think we've solved it. It's simple, it's easy. It's single patient use, it's affordable, and it gives you all those potential benefits that I described, quick onset, less injection pain, and better effectiveness.
So there's a big thread on Dental Town, and it just basically says, do you buffer your local anesthetic? And there's a poll, and it's about 80-20, about 80 no and 20 yes. And the ones that do it love it. And so I'm just going to ask you some of the questions. The first question was, do you also warm your anesthetic? And what are your thoughts on that?
Yeah, I'll take that one. Yeah, warming's fine, but warming then cooling then warming, or warming and cooling multiple times the same cartridge is not good for the epinephrine, and can tend to break down the anesthetic over time. We don't recommend warming, but it does work to make it more comfortable, but not as well as buffering does in terms of taking away the stinging or the burning sensation that patients feel. Warming is always nice, and you can do that by just holding in your hand for 30 seconds before you load it into the cartridge. But it doesn't have the same benefit by far as does buffering.
Yeah.
I think a funny thing among dentists is because um, people around all the advanced countries are so, they want to use their dental benefits. So they're likely to want to stay in network and go to their dentist. And people always think that's the number one deal. And it's really not the number one deal. I mean, dentistry is all fear. I mean, look at every movie in Hollywood that has a dentist in there. It's always a horror show. Even Jennifer Aniston threw us under a bridge on her when she was the dentist. And they're afraid. I mean, it's just fear based. And there's nothing better to build your practice than giving an amazing shot that they don't feel and they're completely numb and you don't hurt them. I mean, if you can just not hurt them, and I also want to tell you that every nerve in your body is the same. They say there's 5 types of nerves: hot, cold, movement, pressure, pain, but you have the same pressure fiber in your thumb as they do in their head. And there's not many pain fibers in the head. It's mostly pressure. And I tell young dentists all the time that, man, if you're feeling, and when you're giving a shot, if you're pushing with your thumb, they're screaming at the other end. If you can deliver that carpule without feeling your thumb, they're not going to feel it. Just go slow, get it tight, go slow, and buffering, whatever it takes. But you just got to have yourself. I remember when I was growing up, I used to go and all through high school, I used to observe dentists. And I couldn't believe how many dentists, after they gave the shot, would put the syringe down, stand up, walk out in the hall, and just exhale. I mean, you could tell they were stressed out of their mind. They hated giving shots. Many of them told me it was the worst part of dentistry. And I just thought, well, if it's the worst part of dentistry, like I would think the worst part of football would be missing a field goal. You would just practice until you got your field goal down, and you got to get a painless shot with profound anesthesia every time. So what? So you prefer? I always preferred Septicane, and I had Stanley Malabed on here. I know some people, over the years they thought that maybe it had a higher paresthesia on a mandibular block and all this stuff. There's just no evidence of any of that stuff. And I got the guru on there, Stanley Malamed, to come and talk about it for an hour, and that episode I think had like 10,000 views. But I switched from lidocaine to Septicane early on in my career. Uh, what
Yeah.
what what are your thoughts on? You said there's seven solutions. Do you
Yeah.
have a place for each of them, or you only use one or two? Or let's
You
talk
know,
the seven solutions.
well, there's two formulas of lidocaine. There's two formulas the two formulas of lidocaine have different amounts of epinephrine, 1 to 100 and 1 to 50,000, both 2% lidocaines. There's two mepivacaines, one mep3, that's plain, probably the one that would be least likely to ever need to be buffered, but you can certainly buffer it to speed up the process because it does take a little longer to get started. And mepivacaine 2%, which is very limited now in its usage. There's a couple of prilocaines, a plain, another more neutral anesthetic where you may not need to buffer, and then they have their 1 to 200,000 version. Those would be the Sit-and-S products. And then you have your articanes, 1 to 100 and 1 to 200. And certainly their pH is not close to neutral and would benefit from the usage of having them buffered. Marcaine, I'm not sure it's ever the first injection, so I'm not sure you would ever need to speed up that process, but it is a slow onset process if it was your first injectable. But just to go back to what Jason was touching on, you know, and what you've touched on as well, Howard, is what's good for the patient is good for your practice. And anytime you can make the patient more comfortable when they're getting one of the scariest things they get when they go to the dental practice, you're making it a little bit more comfortable to receive an injectable anesthetic. And you're actually speeding up the process in which they are numb and ready to go. Um, that's great for the patient experience. And when the doctor can assume those same values in how they treat the patient in a quick way at the end of the injection, they're basically going to be ready to get started working on the patient. You can change the way you practice and really add minutes to your day. And that's really why probably those 20% that you referenced love buffering are buffering because they've realized it's better for their patients, better for their practice. They put more patients in a chair in a day. And that's really what we're looking for at the end of the day.
Townie asks, he says, I apologize, I'm not familiar on this topic. Is there not a pre-buffered lidocaine or articaine available on the market? If not, how come? Is it a shelf life problem? And that's the answer, right?
Yeah, it is.
Yeah, that's exactly the right. And I just mentioned that, Howard, is the idea that you have to make the pH lower to create some shelf life for these products. And then also the epinephrine is, again, more stable at the low pH. And if you raise up the pH for all those people that buffer, one of the other interesting things to remember, if you add the sodium bicarbonate to raise the pH closer to body pH, we call that 7 to 7.4. After you buffer, you should be using the local anesthetic immediately. And that's going to be the directions for this product, BufferPro, is that after the sodium bicarbonate is introduced into the local anesthetic solution, it should be used immediately, right into the syringe and then injected.
A lot of people listen to this show, and I do an hour-long show. A lot of people, they have an hour drive. So let's say they're driving down I-10. Give them a visual of going through the process. I mean, walk them through a visual of this so they can see it in their mind.
So buffering, Buffering, what is it? We just tackled that. It's the idea of adding sodium bicarbonate into a low pH solution. When you raise up that pH, you get those three potential benefits. Quicker action, less injection pain, works better. Now, you could do lots of things if you're a practicing dentist, right? I might wiggle the cheek, I may warm the cartridge, I might distract the patient, push on mucosa. But none of those things give you all three of the benefits. And that's what Paul was saying, is that warming is good, but warming and buffering is going to be way better. Even buffering alone is going to be way better. There have been right now, there are three potential ways to buffer your local anesthetic. One is to just do it by hand. You get a vial of bicarb, you would draw up some of the bicarb and potentially inject it into the cartridge. By doing that, you have several manipulations with a needle, a small tuberculin needle. And also there's some concerns about hand buffering and the stability of the bicarbonate over time. And so that's one way. We call that the DIY method. There's another product from Onset that has been around for a while. And even though I like that product, and it was kind of the first person on the block for dental local anesthetics, the two major negatives that I think of when I think of that product are just that it's kind of not intuitive and a bit tedious to use, as well as it could be kind of pricey, but still a great product, a nice way to buffer cartridges if you're going to go that route. And then this new device for introducing sodium bicarbonate is called BufferPro. And what makes BufferPro special is that it's just a small little device, about maybe 3/4 of an inch long, and it looks like the cap of a pen. And what you do is you just combine the BufferPro with your local anesthetic cartridge in one easy movement, and just push the two together. It injects 0.1 mLs of bicarbonate into the local anesthetic cartridge, and you're ready to go. So no multiple steps are not needed. You don't have to dial up the right ratio. It's always the right ratio. You don't have to do manipulations with a needle. Just bringing those two things together instantly buffers the cartridge. Now, the other cool thing about BufferPro, and we believe that's one of the absolute most special innovations of it, is that it's individually packaged in a foil package. And it's not only just that it's individually packaged, so it's going to be sterile every single time and fresh, but also we packed it in carbon dioxide gas to increase its shelf life, so it won't degrade, which then ensures that each time you open up that foil package, it's going to be fresh and ready to go to provide the buffering that you need. So again, it's just a small little plastic device. I don't know, Paul, you have one you could just show, but it's just essentially just pushing two things together, and actually it's just that simple. No drawing up of like bicarb, no dialing, no multiple steps, one simple step.
One of the other questions on here is how long does the sodium bicarbonate vial last? How many times can you use that vial for other carpules?
Well, that would be the DIY method. And that's one of the issues with the DIY method. And maybe you know more about how many.
Yeah, so that's a good question, Howard. I get that a lot. After all these years of been involved with buffering, the DIY method seems to be the least effective method. I mean, if you spend $25 on a vial of bicarb and you can get 500 doses out of it, my gosh, that does seem like it's cheap. The problem with it is that sodium bicarbonate vials are single use. They're marked single use on the vial, which means they have no preservative and no bacteriostat in them. And according to pharmacy standards, if you're under a controlled hood, the beyond use date for a single use vial of bicarb is 6 hours. When you're not under a controlled hood, the beyond use date for a single use vial of bicarbonate is 1 hour, which means the stability of the bicarbonate in the DIY method is the limiting factor. How many can you get out of it in 1 hour before you really need to throw it away? And so that's what we wanted to do and solve with BufferPro, is that, hey, each individual little capsule of BufferPro contains 0.1 mLs of bicarb, and it's packed in carbon dioxide, which means it's going to be shelf stable for at least 2 years. And the way I use it in the office is I just have a handful of BufferPro in their foil packages in my little lab coat pocket, and I can pull it out whenever I need to. And because of the way we packaged it, it's always ready to go. So we don't need to use vials of bicarbonate anymore. We don't have to worry about beyond use dating, because if there's no bacteriostat or preservative in it, it's going to off gas very quickly, which means it's going to change its pH, and we may be introducing bacteria into it every single time. So to get rid of all that DIY stuff, hey, that's where BufferPro comes in.
Couple things. Actually, Stanley Malamed was the one who first taught me about all this stuff. But there's a article on this PubMed. Do buffered local anesthetics provide more successful anesthesia than non-buffered in patients with pulpily involved teeth requiring dental therapy? A systemic review. Conclusions. This investigation revealed that buffered local anesthetics are more effective than non-buffered local anesthetics when used for mandibular or maxillary anesthesia in pulpily involved teeth. Buffering of local anesthetics has 2.29 times greater likelihood of achieving successful anesthesia. And I mean, it's 2.2. I mean, it's two and a
Yeah.
third times more likely for successful anesthesia. And I'm telling you, man, when you're a dentist, I mean, I can't tell you how many times, flying around for decades. And it was amazing to me how many people I would be sitting by an airplane. I said, I know so many dentists. What's your dentist's name? 80% could not tell you his name. And they'd say things, oh my God, I can see him. He's bald, he's tall, he's this. And they could never. And then when I say, do you like him? Is he a good dentist? God, if they were really enthusiastic, they would just sit there and tell you, well, you see, I don't like going to the dentist. I'm afraid of the dentist, and he's so good, and he's never hurt me, and blah 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 blah. And I'm just telling you, man, I mean, you're sitting there posting all this time on Facebook like you're going to build your practice on Facebook. What I'd rather have is a bunch of patients walking around saying, "I can't believe it." In fact, it's really I did it with kids too when they were real scared and I had to pull a baby tooth, whatever, tooth extractions. I would go in there and I just had this whole psychological thing where I keep their chin up real high so they wouldn't see it coming, and I'd put the topical there, and the assistant they'd be asking, always ask the kid a question right when you go to the insert. I'd put topical, I'd pull the tissue real tight, and then I just slowly put that in there, let that numb. And then as far as the palatal, the palatal is a stinger, so I always let the buccal soak in for at least 5, 6, 7 minutes before I do the palatal. And I had topical in there and gave grate that. And then I would tell them that, I was just checking to see if the tooth is asleep. And I take out my perio, I'm just going to put pressure. And, as you walk that periosseum around the tooth, that starts swelling. And so many young kids, they don't realize that when I see them, they're always breaking off clinical crowns and they have to do surgical extraction root tips. And I tell them, the operatory is not on fire. You don't have to pull this tooth in 30 seconds. Go in there and just keep periosteal and then just elevate it. And if it doesn't budge, put everything down and go do a hygiene check, go cement and crown, because you've initiated all that trauma and it's hydraulic forces of the swelling. And you let that tooth soak for, after you've done the periosteal all the way around. It's not because I think the tissue is going to hang on to the tooth and I can't pull the tooth because the periodontal tissue. It's just to start the swelling and inflammation process. And then I'd start the elevation. And if it wouldn't budge, I would go do a hygiene check. I'd see the crown. I'd go do something else. I'd come back. 10 minutes later, it was significantly looser. And I bet you in 30 years, I bet only 2 or 3 times a decade, I would go back and elevate it some more, and then I'd put it down and give it some more time. But I mean, I got to the point where I was never very good. But what I'd always do with the kids is, I would just set pressure, 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 and I would take out the tooth. And then I would tell the child that I changed my mind. I decided we weren't going to pull it today. And I'd have bite down the gauze. And then I'd walk the kid out myself in the waiting room. And I said, Mom, I changed my mind. And he's biting on a bloody gauze. I said, I know we were supposed to pull the tooth today, but I decided I'm not going to pull the tooth today. And I gave the mom the little deal with the tooth in there, and the mom's looking at it, the kids are, and then I said, and then I'd say, like, Amy, when do you want to come back and pull the tooth? And she'd look at mom like, and the whole waiting room realized, oh my God,
Not you, Paul.
he
I think it's
pulled a tooth, and this kid doesn't even know the tooth is gone. And it's got to be a really big deal, and it's got to be fun. And a lot of dentists turn that around when they get all that stressful patient. They start getting stressed and they start getting passive aggressive, and it just goes to hell in a handbasket. And I always accepted that as challenge on. That's why I went to dental school. That's why we love this job. Really, you're afraid of getting a shot? Immediately, I'm going to tell you, I don't think we're going to give you a shot today. And then they say, really? You're going to do this without a shot? And I'd say, Paul, I gave you a shot 5 minutes ago. You didn't even fill it. And they're like, oh my God. And just burn into their head. It's so
Yeah.
important.
Yeah.
Hey, Howard, one of the things I'll just say is that what you're describing is what your little tricks and techniques, your own way of doing it. And that's also probably one of the reasons why a lot of people don't buffer, because they think they give great injections. They use the best topical, they use the best distraction techniques, they warm it up, they vibrate the tissue, they have all their little things, and they say, I'm doing a good enough job, I don't need to do it. But I'm here to tell you, in 2025, we still can make this experience better. And we could buffer, we could warm it, we could wiggle the tissue, we could use topical, we can do it the kitchen sink approach to make sure that we increase and make that patient experience better for the patient. And you mentioned articaine in kids. One thing I'll tell you is that there's a lot of literature around buffering. And one of the interesting ones recently that I've read is that they did a study on kids where they buffered articaine. And what they did, they asked the kids three questions. One, did you feel it when we did this injection? And they gave a pain score, right? And then they tested like how long it took for them to feel numb. Right? That's great. But the third one they asked these kids was, did it hurt during the procedure? Which is kind of a cool way of thinking about it. And buffered anesthesia was significantly better during the procedure, which then leads to that third best benefit of buffering, better profundity, better depth. And we want to use a great local anesthetic, articaine, for all the benefits it provides. We want to buffer it. We want to use topical. There's just so much room for increasing that patient experience. And we're so excited about BufferPro because it provides all those three benefits, whereas none of those other techniques do.
So you inject the buffering anesthetic into the carpule of the Septodont.
The buffered solution, so the sodium bicarbonate.
And how much of that 8.4% sodium bicarbonate are you injecting in there? About, I think it's 15 to 18 units, about 0.15 to 0.18 milliliters.
0.1.
0.1?
0.1.
0.1 milliliter. That's it, huh?
Mm-hmm.
Again, I like using the questions on the thread because they're real. How long does this process take? How much more time does it take to give a buffered anesthetic shot with Septocaine than not?
Well, it takes roughly 3 seconds to buffer the cartridge. So your dental assistant can do it even before he or she loads the syringe. So here you go. Paul's going to show you.
I just buffered the cartridge. That's how long it takes to buffer the cartridge.
Do it again.
And just push that down and it loads right into the cartridge.
Okay. And then the next question is this a process you would feel comfortable delegating to your dental assistant?
Absolutely.
Yeah, absolutely. And the only thing I'll add to that is, again, the dental assistant can do it. It takes just a few seconds and then they load it up and, the syringe is ready for you to use. Again, it's just that we should be buffering local anesthetic immediately before use, because we get that question all the time. Hey, can I buffer up like 8 to 10 cartridges in the morning and use them throughout the day? And the answer is no, just buffer right before use.
Yeah, what I did now that I can say it, when I had my dental assistant stayed with me from day one till I retired and sold my practice. And I remember one time when she asked me to sign one of the first prescriptions, I said, well, if I sign him, I'm gonna have to sign him for 30 years. Why don't you be the only one that signs him, and then they'll verify your signature? And so we did that for 30 years. I never signed it. And the joke was that if I signed a prescription, it wouldn't get filled from the pharmacy. But my pharmacist, Brad, he thought that was so funny. We did that. Another one is how much does this cost? How much cost does it add if I done with Septocaine? How much more does it cost to do it like this, buffer?
There are 25 units, buffering units in a box. The cost of those 25 units is $90. That's the retail price. And so that turns out to about $3.60 a buffer, a cartridge to buffer. We currently have an intro deal on this, buy two, get one free, and that reduces the cost to $2.40 to buffer an anesthetic cartridge. And, for us, Septodont, we we really want to be in buffering. I mean, for us, we're the world's leading manufacturer of dental injectables, and for us, we wanted to make it as great and as economical as we possibly could. And we tried to develop our own product for 15 years, Howard. It was a chore. We had two projects that started and stopped, and then the last one started and stopped twice before we gave up on our own. And so that's when we saw that Premier was getting ready to introduce their product, BufferPro, and we said, hey, we got to talk to Julie. So I reached out to Julie, see if there was a way we could form a relationship in which we can help each other. And at the end of the day, my main goal became, can we convince them that we can do it better than they can? Because this is where we play. I mean, we make over 50% of the globe's injectables. We make all of the formulas that are used in dentistry. And our mission in life is to make pain-free dentistry possible for all patients. And now, because we were able to form this partnership with Premier, we can say we have all the different ways to provide that pain-free dentistry.
Julie was one of the first people I podcasted. That was 7 years ago. Inspired Solutions for Daily Dentistry with Julie Charleston. She's a hell of a go-getter. I
Oh,
love that.
yeah, she's a firecracker, that's for
Now,
sure.
this thread is going into the fact people are saying, "Will you do it?" I mean, is this for every patient, or is it more mandibular over maxillary? Is it more root canals over fillings? Is it more larger cases over a buccal pit? When do you think it's worth it? And this guy says. The one huge benefit of buffering is for larger cases like full mouth extractions or full mouth fillings. With buffering, there have been multiple studies done that show 1% buffered lidocaine is as effective, maybe more, than 2% unbuffered. So you essentially can double the potency of your local anesthesia for those cases where you might run up against the maximum dosage. And we had an anesthetic overdose death here in Phoenix, like it was like 10 years ago. And then it was only like, it was in the valley here, the Phoenix Valley. And then like 2 years later, there was one down on the border down by Yuma. And my God, it's just frightening that people don't really focus on the limp. I mean, you go to the dentist, they don't even weigh you. And pediatric dentists, they weigh all them kids. I mean, you get on a scale. I don't know a single pediatric dentist doesn't weigh, but dentists a lot of times they don't weigh. They don't take their blood pressure. And this guy's saying that that basically uses half the anesthetic carpals because he's buffering them. But anyway, so I just threw a bunch of questions. Is it every case? Are you more tone maxilla to mandibular? Is it more root canal extraction versus filling? Talk about that.
I'll let Jason go first, but I have some comments here as well.
So okay, so in my eyes, you can buffer everything. Just anybody that wants to give dentist or hygienist a more painless, a quicker acting, and a more profound injection can buffer. Period. I mean, that could be used for every cartridge for every type of procedure where you want to do it better. Now, you had mentioned there was a study that you talked about 2.29 times greater likelihood of achieving local anesthesia. That was from 2019 in the Journal of the American Dental Association, looking at some of the
That's
hardest
right. It
teeth to
was.
numb.
You're good. You're
Yeah.
good.
So looking at some of the hardest teeth to numb, pulpally involved. And so if you think about it, right, maybe you feel like, hey, I'm good most of the time. But for those hard to numb people, those infected areas, buffering is going to make a huge difference. But again, you can use it every patient, every single time.
Yeah. Now, my opinion is that yeah, you can use it on every cartridge for every injection, but if you're going to give more than one cartridge for a patient in the same site and you think you need that, the first one is the one you would need to buffer. And I know many people that buffer every cartridge, but if you're going to automatically give two cartridges, that second one doesn't need to be buffered. I know that's not good for business, but I think it's actually what's right and what's good for the patient and for the practice. The other thing is the plain anesthetics. The sit and nest plain has a more neutral pH. The reason you would buffer that is because you want to speed up the process to get started. The onset can take a little longer with the plain anesthetics. And so in a lot of cases, you're going to want to buffer most of your anesthetics.
Yeah, I would agree with Paul. I think that you want to buffer that first one. The second one, hopefully the site isn't infected or low pH, and so that you get the best bang for your buck out of that first cartridge. But again, we do know people that buffer everything.
Yeah, and I think you're going to use less cartridges even because it's going to be more effective as the
Yeah,
study has
yeah,
shown.
Dennis, I've always, we with Dental Town, if you start your own thread, the first post can be a poll. And so there's so many polls on Dental Town. I love them because they're all in one area. You can read all those polls. But it's amazing how they're mostly influenced by their colleagues. I mean, they're more, and so many people have been started. There's 53 posts on this, just this one thread of buffering. There's a gazillion post threads on buffering, but this one has 53 threads. But five of them said, I started doing it when Stanley Malamed told me to do it. Then it seems like a big consensus are that if you're going to do something that you know it's going to hurt, it's going to be a root canal, it's going to be an extraction, or it's going to be a big case where you're worried that you might start getting your maximum of anesthetic, and then that's when the guys are saying it's a must. And dentistry is like anything, it's a toolbox. You have all these things in your toolbox, and I would rather have something in my toolbox that I maybe don't need on Paul, but I'll use it on Jason, than not having it in your toolbox. And I just cannot tell you that you got to get your shot down. You got to have a painless shot. You got to have profound anesthetic, and you got to be able to tell them that if they raise their left hand, because I'm sitting on the right side, I'll stop. And another thing to the young kids, I learned something. You know how people would joke when we were little about ESP equal, extra sensory perception and all this stuff like that. And I don't think it's even a joke anymore. I've been they just found out that on cyanobacteria. Did you see they just figured out that they're talking to each other, they're communicating to each other? It's the cyanobacteria is the largest of all the microorganisms out there. Cyanobacteria is the largest class by count and volume. It's a big part of why we have oxygen in the atmosphere and all this kind of stuff. And they figured out they were talking, and it was just like 4 or 5 years ago. They were doing those experiments where they were seeing how trees communicate. I mean, crazy stuff. So cyanobacteria are communicating. That's a fact now. You know that trees and forests are communicating. They don't know what they're saying or anything, but they'll. But I noticed when I was the first year, it took me about a year or two. I was sitting there and I was doing some dentistry, and I just said I was thinking to myself, why are you stressed? And I'm sitting there, it's like my heart's racing, I feel tight, I'm breathing hard, and it's like, and I was like, I'm doing like a filling. I mean, it's like, and then I realized, oh my God, I get loops on, and you realize the patient's stressing, and they're hanging on, and they're arching their back, and I started realizing that man, so much stress in dentistry is because you're not realizing that you're hurting 100-pound primate that's only a foot from you, and something in that primate is telling your 100 pounds of tissue that it ain't all good. Something's wrong. We need to go to fight or flight. We need to, you need to get your heart racing and ready to go. And it's just everything just to tone down the pain, the discomfort, the speed, just slow down. I mean, and these dentists, I just tell people just slow down. You get rid of so much of your stress, but you just can't be laying there. You cannot. It's not good for the dentist's heart to be hurting people, because when you're hurting him, that stress is going to somehow be communicated straight to you, even if you're not even aware of their deal. So I would get all the assistants on board, and you know, especially now you realize now they have loops that are 10x. Have you seen those? There's several big threads on Dental Time about 10x loops. I mean, I remember going from 2.5 to 3.8, and then I went to 4. But when you're on 4.5 to 10x, I mean, you're almost seeing the enamel rods. You don't see the person clenching the chair. And the assistant and the hygienist and everybody's got to get involved. I even told the front office, if you walk by and you think they're being hurt, you need to come in here and put your hand on their shoulder and just ask them right in front of me, are you okay? You know, do you need a break? Do you need to slow down? But it's you just can't hurt people. And then as far as everybody always thinks dentistry's you know, it's everybody's going to go to the lowest bidder, and they don't have $3 extra to buffer a shot so that you don't feel any pain during a root canal or an extraction. I just tell them that, you know, Phoenix has all the big major DSOs, and they scare all these dentists. And I tell them that number one, the DSOs, they don't go rural. And they don't go rural because they have a hard time putting a doc in the box. I mean, it's easy to hire a dentist to work in Phoenix. Good luck trying to find one that wants to work in Eloy, Texas, or Beeville, Eloy, Arizona, Beeville, Texas. I mean, it's just hard to keep a doc in the box. But man, I'm telling you, it was amazing in Phoenix how many of those you'd get their patients, and it would get it. Well, I went in there, and the doctor said I had 4 cavities. And you know, you're selling invisible. How's the patient supposed to know that they have 4 cavities? They have to trust you. So they came back 2 weeks later, and they were going to do the 4 fillings, but now it's a new dentist, and the new dentist says you only need 3 or 5 or whatever. And it just, they were satisfaction equals perception minus expectation. I was expecting Jason to do the filling. Now Jason doesn't even work there anymore. And he didn't even tell me what happened to him. And now here's this guy named Paul, and he's saying I have 3. And they just want to go where everybody knows their name, where they trust everyone, and you don't hurt them. You don't need all the fancy dancy. And I can, for you know, when you drive into North Scottsdale, for every $1 million Taj Mahal I can show you of these $1 million dental clinics and have every bill and whistle you can think of, I can show you Midtown dentists in Chandler and Gilbert and Mesa and Glendale and Peoria that are doing bigger numbers and higher net income almost without any marketing, just because of they don't have the staff turnover. They're not hurting people, and it's trust. When you sell the invisible, I mean, when you check into a hotel, Chicago Midwinter meeting last week, and there's a paper slip around the toilet seat. Well, what's that there? Because there's the maid selling invisible. You weren't there when she cleaned the toilet. She gave you a clean glass. She put that cardboard deal in. And dentistry, when I say, Jason, you have 3 cavities and need a root canal. Well, the asymmetry of information. I mean, what am I supposed to do? Can I just run over to Walmart and ask the manager, do I really need a root canal? I mean, the asymmetry of information is so great that it all comes down to trust. And like your infection control is all whether you have a maid source on. They don't know about your statin chargers, and they don't know about your autoclave. They don't know how often you do spore testing. But if there's dust on the boards and you lean them back and there's a ceiling fan above them and it's got black dust rims around the deals, they think it's a dirty office. And if you hurt them, they don't think you're a good dentist. And a lot of dentists always sit there and say, "How come the best dentist in this town? He's got his FAGD, MAGD, he's got a small practice, and then this hack dentist over here, he's not even that good. He don't take much CE, and he's got the $1 million practice." And I go, "Yeah, he's when you walk in there, it's fun. He doesn't hurt them. He doesn't have staff turnover, so he trusts them." I cannot tell you the last. You know, I was a dentist for, you know, over 30 years with Janet Today's Dental, and I'd say the last 10 years, no one even had a question for me. They if they had a dental question, they called Jan because they just felt more comfortable talking to Jan about it. I don't know why. It was because maybe I was the dentist, and they related more to the assistant, or maybe they thought, you know, if it's $1,000, I get all the money and Jan's on hour. I don't know, but man, you got to be pain free. You got to get rid of staff turnover. And I'll tell you what, if you're afraid of DSOs, what you should do is you should find where all four of them are on one intersection and then just go set up there and just say, and you call yourself not corporate dentistry. And, and they come in there and it's small, doesn't have the bells and whistles, and they trust you and you don't hurt them and you explain everything like you're five. And that's another thing I do to these young dentists is, everybody's got an iPhone, record their consultation and then print it out and then get a big black magic marker and go through every word and every line that no one would understand unless you were a dentist. And and my sons do it to me. They're all in their deals, and they'll be telling me something about welding or spray foam insulation, and it's just like all over my head. And usually I got to go to work, and I say, Zach, I'm just going to go spend a day with you because I don't even understand half of what you're telling me. And I'm really keen on that because I know patients don't understand half of what the dentists are telling them.
Listen, Howard, I'm happy we're talking about local anesthetic buffering today because I have never had a patient tell me complain about the fact that they're too numb, but I've had people complain because they're not numb enough. And one of the ways, and you actually asked a question, hey, do I do buffering for root canals and extractions and big mouth cases versus a plain old class 2 composite? Hey, they're feeling the same kind of pain when I hit the dentin with a high-speed handpiece as they would during any other procedure. So I go to the max all the time. I do everything I can to make sure they're as pain-free as they can be. And some people, red-haired people, hard to numb people, people that have had bad experiences, they're just waiting for that pain. So that's why I feel like, at least in my hands, I want to stack the deck on my favor. I'll do the belt and suspenders. I'm buffering all my injections because I just don't want to take that chance. You only get one chance with those people. You hurt them. Sometimes they never come back. So that's how I feel.
Yeah, and everybody, the people that know the value of buffering, there's still many of them that have never tried it because it's not easy to get involved. And today with this new product, and Jason mentioned, this is a very elegant, very well designed product. It's very also simple for dentists to try it. You buy a box of 25 of the BufferPros and you can evaluate it for yourself. It takes 3 seconds to buffer a cartridge. I mean, it's so easy for anybody to now take the knowledge they have about buffering and try it in their practice every day, all the time.
Yeah, and I'm just curious. So Buffer Pro, one word, TM, is this is what ChatGPT says, is a recently launched dental anesthetic buffering solution developed by Premier Dental and distributed by Septodont. And I'm just wondering, why doesn't Septodont, why doesn't Premier distribute it? Why does Premier distribute it through Septodont? And I imagine of Oliver Schiller. He's the CEO of Septodont. Met him in Israel, but he lives in France. So I'm just curious, why did Oliver decide to distribute it instead of Premier?
Well, I think Paul touched on that a little bit, but I'll give you some history. So I've been involved with buffering for a long time, and we had lots of little projects, and people would come to us with things, but we finally decided that we could do it better. And so Premier 100% developed this idea of making buffering really simple. And then we decided that we could make it. So we actually make it in Philadelphia, Pennsylvania. We developed it and make it. But then, as Paul mentioned, we developed this fantastic partnership with the world leader in dental injectables. And that's their space. That's their area. I mean, Premier, you think of Premier, you might think of like triple trays and Traxident and two striper burrs and all the stuff that the consumables that we've had in the past. But hey, who better to partner with than Septodont, kind of that world leader in that space? So that's kind of the long and the short of it. I don't know if Paul, if you want to add anything to that.
No, no, and I was just trying to find a way in which we could work together and that we could be a part of it because, we really believe in buffering. We tried to do it ourselves, but the design that they had was like our original brief. I mean, they designed the perfect product for buffering, and that's why we wanted to be a part of it, and we were able to strike a deal. So,
Does Oliver
happy that.
still, what's Oliver think about all this? Have you talked to him about it?
Oh yeah, he's pumped. Yeah, we're all pumped at Septidon. I mean, we're going to start here, and we'll see where we can take this globally as well. I mean, buffering's not as well known outside of the U.S.
You know,
So,
the
let's
funniest thing about me and Oliver is I didn't know who he was. I was in Israel, lecture like every day for like 5 days. I was at a dental school, and they were giving us a tour of the dental school, and they said this operatory or this area was um, um, sponsored and paid for by Septodont. And I turned to the guy, I said, "Man, that's really cool. I wonder that's so damn cool. I wonder why they did that." And he goes, "Well, I decided to do it." No, I don't. What do you mean you? And then I'm like, "Oh, so you're the owner of Septodont?" And it's funny because when I met him there, I thought Septodont was a French company out of Montreal, Quebec, Canada. I didn't know it was like French even further back than that. It was like past French deal. Okay, so another question says, do you ever buffer anesthetic for ligament jet, PDL injections, or intraosseous injections?
Well, again, you can buffer everything, and Howard, you hit on a cool idea and topic around buffering is that they have done studies where they tested 1% buffered versus 2% unbuffered lidocaine. They also did a study where they showed that 2% buffered articaine was as good or better than 4% non-buffered articaine. So in those spaces where you're giving very little anesthetic, like interligamentary or interosseous, and you're only giving very little actual volume, you want that volume to work better for you. And that's exactly what buffering will do. Buffering doesn't necessarily change how local anesthetics work. They just make those local anesthetics work better. And there's a lot of science around all of it. I don't know if you want to get into those weeds, but for those little volume injections, absolutely. I mean, you can use as small volume as you need to, and you know it's just going to work great.
Before we go, let's change subjects. How is you guys see dentistry at 30,000 feet, and my homies, just sees the dental office. We had that big pandemic. I can't believe it was 5 years ago. Can you believe that was 5 years ago? My God, it seems like yesterday. And it really did change America. It changed these dental meetings. I don't think I've only found one dental meeting on earth that's bigger now than it was pre-pandemic. You know what that one is? Every other year, the AAO, the American Association of Orthodontics, and the pediatric dentists, they combine their meetings, and ortho, that meeting, you can't even get a booth. I mean, that meeting is the only booth space that sells out. Chicago Midwinter was last week. What do you think the attendance was compared to pre-pandemic or a decade ago? Probably half. What would you say?
Oh, pre-pandemic? Yeah, it's not where it used to be.
Yeah, and Dentaltown was a big benefactor of that because the Dentaltown online CE it was literally a nuclear explosion, and all these and now I feel bad because 5 years later they're saying, I was looking at the speakers, but hell, I can see them on Dentaltown, and I don't have to fly to Chicago when it's 28 below zero. But how do you think that there's a lot of anxiety in the air? A lot of people are worried the stock market's overvalued. There's a war in Russia. There could be one in China. How does dentistry look to you? If my homies practice, if he's scared, his practice, what should he think about the macroeconomics of being a dentist in the United States and Canada right now today? Are there good times ahead? Is it going to be a sideways clam walk? Does he need to hunker down? What would you tell our dentist?
Jason, you got something?
He's
You know,
blaming it on Jason. He's
you
like,
know,
I ain't gonna
I was
touch
gonna,
it.
truthfully, Paul, I was hoping you'd take that one, but I'll give you my
I
my
will.
uh, my, my perspective on it. I sit on both sides of the fence because I'm still a practicing dentist, so I'm seeing it in the trenches, and of course I work at Premier, so I'm seeing sort of that higher level view as well. One of the things that I truly enjoy and still do after 27 years is enjoy just sitting in the chair and doing dentistry. And again, I'm so thankful and thanks for having us, Howard, that we get to talk a little bit about BufferPro today because, I still believe that, whether you do digital dentistry or anything else, like the very first part of the procedure that we've been talking about today, local anesthetic, could be the most important. You don't get to do the other stuff until you get that local anesthetic part right. And so the soft skills, the patient management skills, the pain management skills, all those things are really a gatekeeper to the rest of your practice, as you've talked about. And so I like looking at it from the trenches view sometimes. And then when I think about the sort of the bigger view, well, maybe I'll punt that one to Paul because he may have a better
Yeah.
perspective than me.
Yeah, for me, I think it's we're just entering the golden age of dentistry, and I think it's because of, all the things we're seeing and hearing. I've been to so many seminars and research institutes where they're talking about the connection with oral health and overall health. And the mouth is the gateway to the body, and it's where a lot of bad things can actually start and brew. So we need to learn a lot more there, and we need to start treating the patient starting with their oral health, and we can stop a lot of the other things that are associated with um, oral disease, if we can start getting more data out there. I mean, there's a lot of research now that connects the two, and we need to start focusing in a little bit more there, and then we'll see more seats in the seats.
Very good point. And on that note, we're going to call it an hour. And all I want to tell my homies is thank you so much for tuning in. Please leave comments. I read all the comments. I answer all your questions. But seriously, the life is not what comes at you. It's always your response to it. It's like if something triggers you, it's not even what they said or did. It's your reaction to it. And you can blame all your problems on DSOs, and now the current deal is, they're opening too many dental schools, and they're mad at Jason because he teaches at Creighton. It's like they think all the dental schools should just be shut down and all this kind of stuff. Dude, it comes back to your basics. Are you getting enough sleep? Are you exercising every day? Are you going in there into the office and you're rested and you're fed and you're exercise and your attitude's in the right place and you're going to rock it? And you got to have empathy. You got to see yourself from the patient's perspective. And you pull someone's tooth every day. You give a shot 10 times a day. They maybe haven't had a shot in 5 years. They're scared. They're humans. Nobody wants a shot. And I know it doesn't make any sense because they got four earrings in and a bone through their nose and clips in their lip and their whole arm is sleeved with a tattoo. How many shots was that? 8 million, but it doesn't matter because fear is not rational. It's all in their head. And man, if you can just reduce your staff turnover and build trust and be every day at 8 o'clock. I used to tell my staff there's 168 hours in a week. Man, you got 140 hours to go do whatever the hell you want to do. You can beat your wife, your kids, your dog, do whatever. But when you're here, I need the best version of yourself. And they're scared. They don't know what we're talking about, and it's expensive. I mean, my dad owned Sonic Drive-ins, and I don't know what I was thinking because, man, everyone that goes to a Sonic Drive-in, if you've ever seen a human before they eat a foot-long chili cheese dog, a bag of onion rings, and a cherry limeade, I mean, I saw the happiest top 1% happiness out of every customer when they came to Sonic Drive-In. You couldn't beat the smile off their face with a crowbar. And then I picked dentistry where it's the opposite. Everyone's coming in there scared and dude, you got to load up your toolbox. You can't hurt your patients. And if you don't, and you just you gotta have this in your toolbox. I mean, it's just that simple. You might not use it on everyone. I'll give you that, but you got to have it in your toolbox. And especially big cases, root canals, extractions, or even if you even think you're getting close, if you're looking at carpals and you're like, how many times a week do you say to your assistant, how many carpals is that? And she's saying that was your eighth. And you're like, well, but if that would have been buffered, you would have had the effect of 16 carpals in there of anesthetic. So 2.29 more. But on that note, thank you guys so much for coming on the show. It's an honor and a privilege, and we'll see you again.
Thanks, Howard.
Thanks, Howard.